Thank you, everyone, for joining us for today's session. We have been listening to various symptoms in the last few sessions, and today we'll be talking about the role of palliative care in non-cancer illnesses. As we have been discussing from the beginning, how important it is, the role of palliative care in non-cancer illness, possibly due to the trajectories of various illnesses that we see. And today we have Dr. Rutula as our faculty. Dr. Rutula has done her MD in palliative medicine from Tata Memorial Hospital. And currently she is the assistant professor in palliative medicine under Department of Critical Care Medicine at Bharati Hospitals, Pune. Dr. Rutula has her special interest in working with non-cancer and pediatric patients in palliative care. Welcome, Rutula. Nice to see you after a long time through this platform. Welcome to the program.
Thank you for such a nice introduction, and it's really great to see you after a long time. I hope you are all well.
Yes, we are all. Thank you.
Shall I start sharing my screen?
Yes, please.
Just give me a minute. Yeah. Shall I start?
Yes, please.
Okay. So good afternoon, everyone. I'm sorry for the delay. So today we'll be briefly discussing about the need for palliative medicine in non-oncology setting. Next slide, please. So just to briefly revise what is palliative medicine. Basically, it is an approach which is aimed to improve the quality of life of patients, both adults and children, and their families who are facing problems that are associated with life-limiting illnesses. So this is made possible by, as we all know, early identification, proper assessment of symptoms, which can be physical, psychological, or spiritual. So since it is dealing with life-limiting illnesses, a huge chunk of it is non-oncology, which is almost about 80 to 85% of illnesses will be non-oncology, and the need for palliative care is huge, but so resources are limited, especially in our country, as it is mostly focused on oncology, palliative medicine. Next slide, please. So as we know, this is a approach which should ideally start at the beginning of diagnosis of a life-limiting illness and progress over the trajectory and extend beyond the death of the patient into bereavement care. So the role of palliative medicine actually waxes and wanes as the disease trajectory goes. I mean, initially it can be like very minimal, or if there are a huge symptom burden where palliative input is necessary, then it might have a higher role or more of a role, but should decrease once the disease modifying agents have started and the patient is feeling much better and is no more in need for the support from palliative medicine side. Next slide, please. Again, this shows the care bow tie model, basically. So basically, the disease modifying treatment and palliative medicine goes hand in hand and are not mutually exclusive. And again, it goes hand in hand with rehabilitation. And if the patient is getting cured or is completely in remission, then to survivorship, or with end of life care and bereavement support. Next slide, please. So as a palliative medicine physician, there are certain competencies that we should have. We should be able to describe what the palliative care approach is to everyone, not just the patients and the caregivers, but also to the physicians, primary treating physicians who are looking after them, so that there is wholeness in the care and continuation of care throughout their disease trajectory. then we should be able to address all the symptoms, not just pain, other symptoms which can be breathlessness, anxiety, fatigue, anorexia, cachexia, through thorough history taking and assessment of these symptoms, and not just blindly giving them medications according to what has been given previously. So these should include proper physical assessment and relevant investigations, so that we can come to the root cause of the symptom and maybe treat it at that level. Next slide, please. Another competency that we should have is we should be able to participate in the appropriate care of the dying patient and also support their family. So this not only includes identification of approaching death, but also we should be able to describe what the common symptom signs and symptoms are, and how to educate or prepare the family for the inevitable, and support them throughout the phase. And we should be able to do this without getting scared ourselves, or without having second thoughts as to how should we disclose the prognosis or the fact that their loved one is dying to the relatives. Next slide, please. Then we should be able to address all the psychosocial and spiritual needs that the patient may have. There are a lot of tools which are used for screening and assessing, though not very pertinent to Indian scenario, because most of them have been developed in other countries, but maybe it can be adapted and modified according to what the needs for the patient in our population is, and have proper approach to manage these symptoms. And because of the complexities in our culture, given because of the it can be because of the variation of beliefs or culture, religious beliefs, they might vary from place to place, and in a place from person to person. So we need to kind of mix and match and modify these methods. Then we should be able to address the end of life care decision, help in the decision making as well as planning, using the legal and the bioethical framework that is present in the hospital or in the community or in the state, etc. Next slide, please. Then we should be able to communicate effectively with patients, families, and other caregivers. So there should be an honest, frank discussion or communication with the patient if possible. If not possible, then the main decision maker or main caregiver and the families and all the rest of the family members as well. Then we should always approach and attend to the suffering of the patient, which is always multidimensional. It cannot be just one single thing that is causing the patient to suffer. Next slide, please. And amongst this, we should always also care about ourselves and have awareness about burnout in ourselves, because it is necessary for us to be able to give our 100% for the better care of the patient. Next slide, please. So this was just a brief introduction about palliative medicine as a whole, and what are the things that we need to keep in mind while assessing a patient. If I may ask, and it's an open question to everyone, what do you feel are the barriers, or what are the things that you face that make you not be able to provide palliative medicine in a non-oncology setting? Anyone, please. Anyone?
Good afternoon, madam.
Good afternoon, sir.
Yes. One thing is that we never think that the complaints what patients are telling are really related to the palliative problem. We
Okay.
take it as some disease related all the time.
Okay. That is
There is always a tendency to put these patients as pain sensitive, especially with relation to pain care. We tell that this patient is very sensitive to pain, and then we tend to give. There are scenarios where we think about giving psychological support to this patient, psychiatric consultations.
right.
We really do not assess these problems.
Right.
So
Correct.
that is probably one of the things that prevent us from really thinking into what this care is.
Right. Correct.
And I think, Dr. Rutula, there are a few comments in the chat. Can you access chat from your side?
Yes, ma'am.
There are many comments coming up in
Yes.
the chat if you are interested to take it up.
Yes. Correct. So the time needed to address these issues within a consultation is limited. Yes, the disease, like we are not very confident about the disease trajectory and how it proceeds as well. Then the continuity of relationships with the patient. Yes, lack of awareness is a major concern, and the unavailability of resources is another one. Correct. So basically, we don't have any awareness about palliative care in non-cancer patients, and the trajectories are important. So next slide, please. So as we were again, so the trajectories are important. So as we all know, the 4 roads to death. One can be a sudden death because of an unforeseen event. One is a terminal illness, which is most pertinent to cancer. Then organ failures, which has waxing and waning, going up and down. There are troughs, there are elevations, and which lead to slow deterioration and death. And frailty, which is basically a normal aging process. So what happens is, because of the mostly non-oncology setting, will be looking at organ failures and frailty. So what happens in organ failures is that the trajectory is not constant. They might sometimes be well enough, and we can just feel like they're okay, they are normal people, they don't look as though they have any disease. It is that well maintained. But when they have deterioration, there is it might be because of infection, it might be because exacerbation underlying, but more often happens is because when you give them the appropriate management, or you go aggressive on them to control the disease per se, they come out of it. They usually come out of it, and again, not as they were before, but they come back to the near normal state before the exacerbation. And most of the time, though because this happens multiple times over a large number of years, so every time the patient comes down with an exacerbation of the disease, the patient himself or herself and the relatives always feel that, okay, this just needs this many days of admission and this many drugs, and he'll be okay, and he'll come back to what it was before he became sick. So the trajectory itself is a huge hodgepodge of multiple things, and usually initial part of it, always the patient manages to come back to near normal level of the functioning he had before. And frailty, as in general, people don't generally, or everyone takes it as a normal thing that is happening in our life, that slowly will come down health wise. Like, you become frail, you become you start eating less, you don't often have energy to do a lot of things. So we take it as a normal thing that is happening because of our aging process, and they don't feel that there is need to involve another physician or anyone else to just look after that. Next slide, please. So in non-oncology, mostly, as I said, it's organ failure, neurodegenerative diseases. There can be rheumatological autoimmune diseases, cancers, and prolonged ICU illness, which may or may not be because of the organ system failure, but sometimes just acute event leading to a prolonged ICU stay, not getting better, and may require interventions from palliative medicine side. Next slide, please. And so again, can you just click one more time? So what are the perspectives from the physician side is that they are always aiming for cure, and they're like, we are experts in this, we will manage, we will get them better, and they don't want to give up. It's like, my patient, I know how to manage him, he's been with me for so many years, and I want him to get better. And if by chance he or she is not getting better, then they take it as a personal failure, and they get distressed about it. And again, as we all said before, there is a general lack of knowledge in physicians across the country, across the specialities about palliative medicine. Next slide, please. So in views of in from caregivers perspective, what do you think would be the causes or the barriers that they have, or what they have against the referral from palliative medicine? Anyone? Yes, Vandana ma'am, you've raised your hand.
Yeah, good afternoon, ma'am. Yeah, in this case, I would like to just say that many times the caregivers have a problem with palliative care because it's not a one-time visit that they have to come for. They
Right.
might have to come many times, and it requires time, it requires dedication, accessibility. So it's not something that, you come for one consultation and it's done. So
Right.
that is one reason. And again, lack of awareness among the, and they may not be really having the confidence that this is going to get the patient treat or the patient. That is another aspect in the caregivers think about.
Yeah, I agree with you. That's an interesting point that you brought up. Actually. Thank you. Anyone else? Okay, on the chat, yes, they feel very guilty about again giving up on the factors, social factors, right? What will people think? Or then again, yes, inability to understand the course of the disease, giving up, betrayal, guilt, fatigue, exhaustion, lack of awareness. Correct. Ma'am, next slide, please. Just click one more time. So again, it is basically the disease trajectory. They want everything to be done for the patient. They want to give everything, the guilt, and what will people say? This is always a huge thing in our country. Next slide, please. So I'm not going to go into the details of all the diseases that are there in various systems. I'm just going to briefly mention few of them which usually present or usually have palliative medicine needs. And we'll discuss the symptoms and maybe touch upon their management a bit. So in CNS, usually we come up with dementias, we have Parkinson's disease, we have brain injury. It can be traumatic, then stroke, vascular stroke, or ischemic stroke, all these. So basically, next slide, please. So these present with various symptoms, which can be all of them or few of them. Then might be seizures, you have plesias or paresis. So basically hemiplegia or hemiparesis, paraplegia, quadriplegia, etc. You have all those dystonias. You might have dysphasias, aphasias, you memory disturbances, and headache. Like usually they'll may present with a headache, raised intracranial tension symptoms, etc. Next slide, please. So in brief about the management of all these, so basically rehabilitation, this goes across all the systems and all the diseases that we are going to see. So anywhere where you can provide them with rehabilitative measures or non-pharmacological measures, give it. It is first thing is is like you can just teach them at first consultation or second consultation, whenever, and you don't have to do it every time because they'll keep on managing it afterwards. So rehabilitation is an important step all through the disease processes, disease trajectories, and all the diseases. If muscle relaxants or baclofen, as we say, might present with like hypertonia or spasticity, or even sometimes in dystonia, muscle relaxants can be used to relieve the symptoms. Analgesics plus minus, if there is pain, which is like usually muscle relaxant might help with the pain as well, but if it is not, then maybe adding another analgesic, which can be an opioid or a non-opioid, might be helpful in appropriate doses as seen fit by the physicians. Then seizures or in neuropathic pain, use of anti-epileptics and are important whenever needed. So this is a bit of a controversial thing. Sometimes and nasogastric feed or peg feed might be necessary for the patient, especially if they are early in the trajectory of the disease process. Some feel that it is not necessary or shouldn't be done because it's an invasive thing, and you don't want the patient to go through that. So this varies from physician to physician. I would personally want to go for it because feeding is necessary, especially if they are early in the disease trajectory. So and also will help prevent the other complications such as aspiration and infection afterwards. So might be helpful to put it in before. Then aids for speech and communication. So there are various things you can teach them measures to, like the blinking measures, or you have those laser equipments for communicating in a patient who is unable to speak, or locked in syndrome, etc. So these are a few things that might be helpful in managing these symptoms. Next slide, please. So in CVS, as we said, major diseases that will be referred for palliative medicine would be heart diseases. Various causes of heart diseases might include a congenital heart disease. There are coronary artery diseases. Then obesity leading to heart failure is one of them. Then you have your valvular diseases, heart diseases. Then certain toxins, if used, may lead to heart failure, for example alcohol or cocaine use, etc. Then Eisenmengerization or Eisenmenger syndrome might have high requirement for palliative medicine. Next slide, please, ma'am. So various symptoms that we see in cardiovascular system would be basic. First would be breathlessness and chest pain or heaviness. There is palpitations, which the patient perceive as heart racing or having the feeling of anxiety or something going wrong. Then there is edema, cough, fatigue, and sleep disturbances. Next, please. So as I said, rehabilitative measures all across the board. So those are necessary wherever possible. So opioids can be used for the pain as well as for the breathlessness. Might sometimes even help with the palpitation because of the preload that is getting relieved with the use of morphine. Diuretics again help to reduce the preload, as well as with the edema. So it will help bring down the edema, and the preload on the heart might help with the breathlessness, like the breathlessness component, because of the fluid overload, and might help with the pain as well. Again, beta blockers plus minus for the palpitations in the heart racing and feeling of anxiety that the patient is going from. So again, wherever it is possible to use beta blockers, it might help with the symptom management. And O2 support, of course, if whenever the patient is requiring, the saturation is going down and he's having a lot of symptoms because of that, or he's not able to function without the O2 support, then again O2 support whenever required. Other things that can be used is the for breathlessness. Usually whenever we say non-pharmacological measures for breathlessness, so the handheld fan and other rehabilitative chest physiotherapy measures and pursed lip breathing, all those things can be applied here as well. Next slide, please, ma'am. In respiratory system, so we have end-stage lung diseases, which include COPD and interstitial lung disease. The right side heart failure because of primary lung pathologies, which we call as cor pulmonaire, and pulmonary embolism, which lead to high symptom burden, especially if not treated early on. Next slide. Again, so symptom profile of cardiovascular system and respiratory system might overlap a lot. So we have breathlessness, fatigue, palpitations, headache can be present. There is weight loss, especially in COPD, because there is a lot of protein loss and everything in the cough as well. So weight loss is another sign. Next slide, please. So again, rehabilitative measures, especially with the chest physiotherapy, where they can help you breathe better and use the lung capacity to maximum, whatever is left. Opioids here play an important role, especially with breathlessness and pain as well. Diuretics might not help if sometimes there are studies which show that nebulization with furosemide helps in breathlessness, but it's not all across the patient population, but few have responded. Then an acetyl system helps you loosen up the secretions that are there. So nebulization with an acetyl system has shown to show symptom improvement and to cough out the expectorations that are present in these patients and make decreases the breathlessness in these patients. O2 support again as and when required. So these patients might often suffer from delirium, might be because of hypoxia or any other electrolyte disbalances or any other causes of delirium. So use of antipsychotics might be necessary in these. Then steroids again play an important role, especially if there is infective etiology, or in COPD also, to just reduce the edema in the lung, to just for symptomatic relief, to give better symptom control. Next slide, please, ma'am. So hepatobiliary, so end-stage liver diseases, so it might be liver failure or liver cirrhosis, which can be due to various reasons. It can be you have your chronic hepatic infections, like hepatitis B or hepatitis C, which lead to cirrhosis and failure, or you have your alcoholic related cirrhosis or liver failure. Then you have your non-alcoholic fatty liver disease, which might also lead to liver failures. Then you have your autoimmune hepatitis as well, which basically lead to your end-stage liver diseases. Next slide, please, ma'am. So here the symptoms profile is a bit different. There will be a lot of nausea, vomiting. There will be fatigue, weight loss, then signs of liver failure, as we all know. So basically jaundice, ascites, you have your pruritus, then your spider nevi and your pedal edema. You have your esophageal varices and bleeding from all the systemic, portal systemic anastomosis regions, and bleeding otherwise also because of liver dysfunction. All those. Next slide, please. So here the management is different. Rehabilitation, again, wherever we can provide them with rehabilitation, that is where it is required. So any thoughts among which antiemetics would be appropriate in the setting of liver failure? Any examples? What do you think is the likely cause of the nausea and vomiting, and what is the ideal choice for the nausea and or vomiting here? Anyone? So basically, it will be a centrally, the preferred choice for antiemetic will be centrally acting antiemetics. So maybe, ondansetron or your haloperidol if necessary, if it's not responding to on them. Metoclopramide can be used, but again, you'll have to monitor the patient. You should not have any extrapyramidal side effects and should not have colic as well. Because sometimes there might be constipation associated with hepatobiliary diseases. So haloperidol, olanzapine, not so much. I'm not. Olanzapine can be used again. So any centrally acting antiemetic will be the preferred choice of antiemetic here. So for pruritus, sertraline is one of the first line treatment for pruritus. Then another alternative is rifampicin. Starting dose is around 150 mg per day. Then the another second line will be danazol. You can use danazol for if available for pruritus here. And another drug, it's third line drug for here. It's all these, what I'm saying is basically for cholestasis, it's cholestatic pruritus, but can be extrapolated to liver cell failure. So the third line will be naltrexone. It can be used for pruritus because of actually cholestasis, but can be extrapolated to liver cell. Then, as I said, there can be constipation here, and if the patient is going into hepatic cellular failure, so laxative, which would be the laxative, and why would you use that? Like, yes, rifampicin in not in liver failure, ma'am. It was I was talking about pruritus. It's not for liver failure. It was for pruritus. Drug of choice for hiccups in liver failure, I would prefer haloperidol. It'll help with the cholestasis, mostly because repeated ascitic tapping might be required as and when required. Yes, because usually by the end of it, you might require it to do tapping every week, if not every other day. So which laxative would be preferred? Like, which would you give generally for patients with hepatic failure? Anyone? What? Yes, lactulose. Can you tell me why? Just
excess ammonia is convert.
exactly. So that should help with the NKF part of the liver cell failure as well. Thank you. And any other supportive measures, as you said, ascitic tapping or physiotherapy or any other non-pharmacological measures that you can give, and it can be used. Next slide, please. Renal diseases. So end-stage kidney diseases, it can be because of glomerulonephritis or diabetes, or chronic high blood pressure, which is not getting properly managed. Next slide. So the symptoms usually that present would be nausea, vomiting. There is decreased appetite, a lot of fatigue, decreased urine output, signs of fluid overload, which can lead to edema, chest pain, breathlessness, headache, blood pressure, which is not getting controlled with medications, pruritus again, muscle twitches and cramps, and so any thoughts about management of all of these symptoms, wherever, like whichever. Next slide, please, ma'am. What will be the antiemetics here? Will it what would be the cause of nausea here in renal diseases? So generally it will be uremia, which is causing a lot of nausea here. So again, a central effect, and again centrally acting antiemetics. So again, 5-HT3, haloperidol, antipsychotics, haloperidol, olanzapine, etc. So itching, like antipruritic agents, what would be the choice here? What would act better? So first line here is generally your local application. So capsaicin is a good agent for uremic pruritus, and photo UV rays therapy, UVA, UVB, I think UVB phototherapy is used for uremic pruritus. That is first line of management. Second line would be your gabapentinoids, gabapentin, starting dose 100 to 300 mg per day. And third line would be your sertraline, which was first line for cholestatic pruritus. Laxative, again, I was going with lactulose only. We've discussed that before. So that, and again, supportive measures as and when required. So hospital admission for infective reasons, which you feel that would help and benefit the patient, and it's not immediately leading to death, there it might be validated. So, or any such measures which help improve the quality of life and the condition of the patient should be given to the patient. Next slide, please. So because breathlessness is present almost through all the diseases, I thought that we should just briefly touch upon the breathing, thinking, functioning pattern of breathlessness. So, these are various things that will lead to the vicious cycle, leading to a lot of breathlessness, which might not be adequately controlled with opioids. So we need to think about the potential reasons for breathlessness, and address them accordingly. So, you should not just be focusing on the pathophysiology of breathlessness, but also the functioning of the patient himself or herself. Is there deconditioning of the chest wall muscles, or any which might benefit from chest physiotherapy and breathing techniques? Is there any sources of anxiety or misconception about their disease trajectory or disease status, which is leading to a lot of anxiety and distress and panic in the patient, which is kind of adding on to your breathlessness? So you need to address all these things and manage the breathlessness accordingly, or rather manage it holistically in any given patient. Next slide, please. So coming to end of life care, It's I think it differs from place to place and from hospital to hospital. So this might not be uniform to all and everyone, but I'll just briefly touch upon it. Next slide, please. So this was the flowchart given by the Indian Society of Critical Care Medicine. So basically, what they said was that once the patient is admitted to a ICU, this was basically an ICU, then you should kind of assess the patient regularly, and if you feel that there is a prognostic uncertainty, then they should discuss it among the treating physicians initially and come to a consensus as to whether it is actually futile or the prognosis is grave. Then after that, they said that they should have like a very honest communication with the caregivers and the family members to disclose the said prognosis and offer them the option of palliative medicine if they have poor outcomes. Then once the consensus has come from the family side and the physician side, then they should come up with a plan to like what the care plan of the patient is. And then if there are conflicts, then those are addressed. So anytime there can be conflicts, so that should be addressed overall. And it should be a very transparent discussion and planning, and all should be documented that we've discussed. This came up, so again, this was discussed, family meetings if necessary, everything. It all should be very transparent and should be documented. And if, because this was in the ICU, so they were assuming that there will be patients who are already ventilated or will require ventilation down the line. So it should be clearly mentioned whether to go for such invasive measures if not already on it. And if they are already on ventilation or any other invasive measures such as inotropes, or the patient is requiring daily dialysis, etc. So should you withhold the said treatment? So this should be also clearly documented and clearly discussed with the family members and the patient if possible. And then offer them just comfort care. If they agree with withholding or withdrawing, just offer them comfort care or palliative medicine as they call it. And then suppose they agree with comfort care, then give the patient a bit of laxity, as in the visitation hours should not be bound. Then they should maybe discontinue all the life prolonging measures that are already going on. Address all the psychological, physical, social issues that the patient or the family members might have. And if the patient wants discharge, then if possible discharge, or maybe shift them to a isolated room where it is they have certain amount of privacy and better closeness with the loved one that they would want during the end of life. So this was for critical care unit mostly, but it can be kind of taken up for non-ICU patients as well. Next slide, please. So this was what I got from their side, that where and how we can proceed with the trajectory. So they might present either in the emergency department or in the OPD or in the ICU or in the wards. And there are relatives also. The patient can be there or the relatives can be there. So if there is a prognostic uncertainty, then after the consensus with the physicians, we have a discussion with the family members and the patient and establish what their goals of care are and where the preferred place of care is as well. Then accordingly, if they want to withhold or withdraw life-sustaining treatment, then offer them comfort care, or if they don't want to go for that, they want to do everything, offer them the same amount of care as well, even if they proceed with the life-sustaining treatments. And again, document everywhere, document everything that you've done, you've said for all these patients. Next slide, please. So we are coming, it's an end of the discussion actually. So basically we have a long way to go, especially in non-oncology patients. And there is, as we've discussed, there is a lack of awareness, not only amongst the patients, but also amongst the physicians. And they are very skeptical about our role in the said diseases and disease trajectories. But I think once we show them that we can help them support the patient and that we're not going to encroach on their territories, if that is the right way to put it, I think they'll be supportive of us and we will be able to provide the best care that we can for these patients. Thank you. Next slide, please. Thank you. Any questions or anything that you want to ask? Or any comments?
Thank you, Dr. Rutula. We can take up a few questions before moving on to the case presentations. And thank you so much for the presentation. I felt this was more of a practical presentation, like how do we manage non-cancer illness than giving an idea of what is happening. Thank you so much.
Thank you. So I forgot in the sense I have not mentioned a lot about fatigue, but that is an important symptom that is present in all the diseases, including cancer. Not a lot of pharmacological measures that can be used for fatigue, but we can give a bit of physical rehabilitation, as in, light physical activities, like maybe go for a 15-minute walk if possible. If not 15 minutes, then just start off with 5-minute walk, let them rest, then they can continue for another 5 minutes or something like that. Just very light physical activities and kind of maintaining a routine for the patient. So for example, not letting them be alone in one room throughout the day, making sure that they have their meals with the patient, with the relatives and all the family members, so that there is a, they are not alone and not only concentrating just on one thought throughout the day. So that helps. And distraction measures, any distraction measures which the patient finds comfortable. So usually we'll go with the hobbies. So listening to music or singing if they like it, or reading, or crossword puzzles or Sudoku, anything that can help the patient. So these are just the general things. There are a few comments. So I feel symptomatic management to keep the patient as comfortable as possible. Yes, that is true. So basically it is to, I personally look at it as a supportive method for the patients. So as a supportive measure. And so anything, it might not be just physical symptoms, it can be psychological, spiritual, anything that we can help with. Giving IV fluid is very acceptable method in this part of the country for fatigue. Yes, so that has a component of psychological well-being also, that usually our patients feel that ki are saline laga diya to patient theek ho gaya. So usually they feel that. So giving IV fluid does help with fatigue in many of the patients.
Have we already answered the question on the medicine for hiccups in liver failure?
Yes,
there is a question.
Yeah.
Okay. Sorry, I missed that part in between. So I was just ensuring that we have covered that part.
Yes. So metoclopramide can be tried, but haloperidol will be more preferable, because it's not the motility that is affecting not the cause for hiccups here.
Are there any other questions from your personal practice? At least some of you, I think, might be seeing a lot of non-cancer patients needing palliative care. So this will be a opportunity for discussion. If there are no questions, I think we can take up the case presentation and we can discuss that. Yes, sorry, Dr. Vandana, please.
Yeah, ma'am, thank you for this opportunity. One last question before we move to the case. Ma'am, don't you think that in non-cancer palliative care, most of the treatment will be more of inpatient kind of treatment than outpatient? Because considering these patients, the common patients are multi-organ failure, ICU patients.
Right.
So, don't you think most of them will be inpatients and yeah?
So I agree with you that at least the first consultation is mostly when they are either admitted to the wards or in the ICU. But if by chance they have considered withholding in the ward especially, and they are able to go home with maybe oxygen support and few other medications, then we might have to follow them up at home. ICU generally, if there is withholding or withdrawing of support, then usually they will keep the patient in the ICU because the prognosis might not be more than a day or two. Because if they are replacing all their supports, then generally the lifespan won't be more than few hours, 2 days, maximum of 2 days or 3 days. So for ICU patients, I agree they'll be inpatients. In ward patients, or sometimes the patients are referred from these specialty OPDs to you directly for symptom management. So there might be certain places and certain areas where you might have to do OPD consultation or home care for these patients as well. Yes, metoclopramide. Yes, that's one of the worries that we have with metoclopramide are the extrapyramidal symptoms. So again, that's why I would prefer haloperidol in these patients.
Just adding on to what Rutula mentioned about the type of care, IP, OP, and home care, I totally agree to that. It's not just IP. Sometimes it's entirely an OPD basis, or sometimes it can be home care basis. Because in our scenario in Kerala, what happens is that we get patients with who are not imminently dying. They'll be there for a long period of time, especially with neurological, degenerative neurological illnesses, or children with. Today's case presentation is about a child, so we have a lot of people under that category, which may not need IP admissions unless there is an acute exacerbation.
Exactly.
They are largely taken care of by the community, except when they have an acute exacerbation, they might need an IP care, and then they are sent back to India. It entirely depends on where exactly in the trajectory they are in.
Yeah.
There is another comment or question.
Role of step 4 therapy, especially physiotherapy, consultation for symptoms of chronic fibromyalgia, like symptoms. Exactly. So as I said, physiotherapy and rehabilitation goes hand in hand throughout the disease trajectory and across all the diseases that we saw. May it be like CNS diseases or respiratory or cardiovascular, everywhere it helps a lot. And actually it might even help in reducing the pill burden as well in patients many of the time, because they kind of just relieve the symptoms, so kind of the need for the medications also goes down. Some diseases like sickle cell disease will require long-term home-based care requiring admissions only. Yes, exactly. And again, giving them medications for any acute symptom is okay, like till they come to the hospital where they can be further managed with whatever is required. So if sickle cell crisis, generally, like they have severe pain and which may most of the time is not controlled with just plain paracetamol. So giving them just one strip of morphine and just tell them that if it is a severe pain, then just give it till you come to the hospital. So at least, they are relatively okay during that time. Then if with IV management and everything, they'll be managed after that, but for the time being at least.
Thank you so much for the questions and the comments from participant sides and your inputs. So we'll move on to the case presentation and further discussion after that.
Yes, thank you.
Dr. Pratima, you can start from your side.
Hello, good afternoon. Am I audible?
Yes, you are.
Yeah. So I'm Dr. Pratima Bisain. I'm currently working as a pediatric palliative care medical officer in Nair Hospital, Mumbai. So today's case is a 7-year-old male child who is a case of spastic quadriparetic cerebral palsy with global developmental delay. So the child presented to us with the complaint of cough, fever, and breathing difficulty, seizure episodes. He has already problem of global developmental delay. He is suffering from irritability and sleep disturbances. He has hypertonia or stiffness of the body, dystonia. He has problems of feeding difficulty and constipation also. The history of illness is like the patient is a 7-year-old boy. He is a case of cerebral palsy and he has significant birth history of perinatal asphyxia. That is, he did not cry immediately after birth. He is currently living in suburban area, which is far away from the hospital, around 40 kilometers away, and he is living with his elder brother and parents. Child has global developmental delay. With delay in all the 4 domains of the milestone. He has an ability to sit or walk or even speak. Even the head holding is not achieved even at the age of 7 years. So he is basically bedridden child since birth. Child also has complaint of seizures since day 16 of life, now partially controlled on anti-epileptic medications, but breakthrough episodes occur, they keep on happening in between. There is a problem of neuroirritability also with disturbed sleep pattern. There are feeding difficulties in the form of swallowing problems, coughing during the feeding, excessive drooling, long meal times, and constipation. Child also has frequent respiratory infections and breathing difficulties because of microaspiration, maybe due to chronic bedridden position. There is also tightness of body and contractures of hand and feet. Next slide, please. So on examination, child is conscious. His temperature was 98 degree Fahrenheit. Pulse rate was 110 beats per minute. He was tachypneic with respiratory rate of 38 breath per minute with subcostal retractions were present. His blood pressure was 80 by 60 mm Hg. His saturation was 95% on room air. On central nervous system examination, he had hypertonia of all the 4 limbs with hyperreflexia, reflexes 3+ in all the limbs, and ankle clonus was present. The plantars were bilaterally extensor. In respiratory system examination, extensive bilateral V's was present and subcostal retractions were there. Rest of the systemic examination was normal. These are the treatment and significant investigation. In view of breathlessness, chest X-ray was done, which was suggestive of bronchopneumonia. His EEG was suggestive of multifocal with generalized epileptiform activity with mild asymmetry in both hemisphere. He has his MRI brain, which is suggestive of patchy areas in bilateral frontal parietal and parieto-occipital periventricular matter, which can be sequelae of mild perinatal HIE. There was partial agenesis of posterior body and splenium of corpus callosum. So in view of extensive V's, patient was started on salbutamol nebulization. and in view of bronchopneumonia and fever, he was started on intravenous amoxiclav. For fever, syrup paracetamol was given, and for constipation, syrup lactulose was given. Next slide, please. So these are the this is the social aspects. So mother is basically the primary caretaker of both the kids. She is housewife, but they have small pan patti shop in their house, which is handled by mother and the elder son who is just 10 years old. Because the father is not that supportive, he is chronic alcoholic, he doesn't earn, and he even takes away the money which is earned by mother in this pan patti shop. Mother is very sad and hopeless because she feels that she has to handle everything alone. She feels exhausted and burnt out as she has to look after the financial issues, social issue, household issue, and she only has to every time come with the child to the hospital with negligible support from father. Mother is constantly worried about the education of her elder son also, who is 10-year-old. She wants to give good education and future to this child, but has lots of issues going on simultaneously. She sometimes feels that she is neglecting her other child in caring for her this chronically sick child. There are repeated admissions because of frequent respiratory infection. As she lives very far away, there is lot of transportation cost, and during those days she even suffers from loss of her daily wages. She has to carry her 7-year-old kid, as the child can't walk and speak, to the hospital on her own, and this is causing her chronic back pains also. Next slide, please. So these are the medication going on for the child. The child is on syrup levetiracetam and syrup valproic acid for the seizures. The child on tablet gabapentin for neuroirritability, and child is on syrup paracetam for spasticity and tightness of the body. So these are the main concern. The following are the main concern. That child has to get repeated admissions to the hospital because he suffers from frequent respiratory infections. There are feeding difficulties in the form of drooling of saliva, long meal time, choking during meals. There is disturbed sleep. Child is not able to sleep at one stretch in night. He wakes up in between due to neuroirritability and other issues. There is social stigma as the child is specially abled. She suffers from isolation. The mother has a feeling of not doing enough for her other kid. She feels anxious, depressed, and burnout, and worries about the future of her child. And she suffers from back pain due to carrying her 7-year-old child. She has spiritual concerns also. Ki why am I suffering from this? Is it because of my bad deeds? There are financial concerns as well. She is losing on her daily wages whenever she is in the hospital, and transport cost is also there. Next slide, please. So the summary of the cases: it is a 7-year-old male boy with the global developmental delay and spastic quadriplegic cerebral palsy. So I would like to have some discussion points. So first question is, what are the problems and health related suffering faced by this patient? Yes, anyone?
Maybe we can take up the questions together. Like we can.
Yeah. Should I read all the questions, ma'am?
Yes, ma'am.
Yeah. So first question is, what are the problems and health related sufferings faced by this patient, and how can these sufferings be managed? What all can be done for this patient and his mother and family members too, which should be discussed under broad headings of physical care for the symptoms, psychosocial care, spiritual care, and what kind of other support also can mother be provided?
Thank you so much, Dr. Pratima. Like it's a very different. I think this discussion will give a very different perspective in terms of non-cancer palliative care.
Yes.
I would like to hear from the participants. What do they think? What all kind of support can be given? How can the suffering, and is the suffering? Isn't it very evident? Like what they are going through? We generally, I think in many parts of our country, we generally don't think this probably under palliative care scenario. But
Yes, ma'am.
I would like you to think about in a palliative care lens, what are suffering they go through,
Yeah.
how can we
Yes.
help?
So, ma'am, this patient is basically bedridden since birth. So there are various, in terms of like if I talk about the physical suffering, the child has many problems, not not just like one problem. Since birth, he's suffering from seizure episodes, which are like partially controlled on medications where they happen in between. The child has feeding problems, because the child can't sit. He's constantly in this lying down position. There are micro aspirations. There are long feeding times. uh, because of all this spasticity and neurological suffering, there is problem of autonomic disturbances. There is constipation also. So basically seizure is there, tightness of body is there, constipation is there, and other than that, this global developmental delay problem is also there. Child can't walk, can't talk and all. So these are the physical sufferings which needs to be taken care of. Yeah. And apart from that, this is the like basically physical suffering. Apart from that, there is like psychological impact on the family as well. Like mother has to care for this child since birth. The child is bedridden, so as in normal scenario, as the child grows, the child learns to manage his thing on his own. But here everything is like being managed by mother. The child is like in neonatal type of condition. Since birth till 7 year of age, the mother has to take care of each and everything, like food. Even the bowel bladder function is not developed, so she has to do that. These are the things. Then the other thing is like, there is some subconscious comparison. Why my child is like this? There may be comparison with sibling. The my other child, he is able to walk normally. He is able to do his work normally. Why did my child suffer from this? Sometimes what I have seen, they come with the complaint that I did everything during my pregnancy. Their concern is from antenatal period only. That I did everything properly. I got all the scans done on time. I took all the medications which doctor prescribed me, and there was nothing in the previous scans. So how did my child suffer from this? Did I do something wrong? Did I not care for the child? There is a lot of confusion and guilt also. So these are the psychological aspect. The other third dimension, I would say, is the social dimension. She has to repeatedly come. Since the child is born, she has to come to the hospital. And this case is not only like can be managed by neurological team. They have to go to multidisciplinary approaches there. They have to go to 10 specialists for the child. They have to go to ophthalmologist for ophthalmological evaluation. They have to go to ENT doctor for hearing evaluation. They have to go to physiotherapist. They have to go to dietitian. So it is really exhausting for them to be sent to 10 different specialist people. Repeatedly they have to go follow up many type of investigation. They have to do MRI, they have to do EEG. Then they are on anti-epileptic medication. These TDM levels have to be done again and again. That why are the seizures not getting controlled? So it is really very very exhausting for the parents. They have to lose on their daily wages. They have to spend so much money on the transport as well. So these are all like it's a Pandora of issues which the patient and the family is suffering from.
Thank you, Dr. Pratima, for sharing those concerns with the team. So there are a few suggestions on training the patient to prevent aspirations, and maybe involving other family members like brother, father, and counseling the mother to kind of taking treatment
Yes,
from
yes.
the local.
Very right. Very yes. In terms of feeding issues, the positioning is very important, and right kind of dietary advice is also important. So mother can be advised on making thick feeds, which do not choke the child while the child is feeding. Proper positioning is important. So these issues can definitely help in reducing that frequent respiratory tract infections, and can also help in the weight gain and providing proper nutrition to the child. Yes.
I think
Actually,
there is something on de-addiction of father, if possible, and very valid point by Dr. Muhammad Sajid. Support groups will help
Yes,
probably, like
yes,
people
yes.
with similar this thing. They'll get one or two things which they can adapt to their lives also. Sorry, someone wanted to talk. I
yeah,
interrupted.
I was just me. So, hi Pratima, hope you're doing
Hi,
well.
hi, hi. You know, say-
Maybe you can consider putting an NG tube for the child, like because if she's working also simultaneously taking care of the child and the feeding time is long, and it might even just prevent the aspiration episodes as well, because as you said, there was a lot of choking and coughing during the feeding, so that can help with that, and we can just actually have like a proper diet plan for the child for weight gain and everything else as well. So
yes, yes. Yes,
yeah,
that can be done. I think so. That is a good suggestion. That can be done with proper dietary advice regarding calorie dense
yes,
with
exactly.
feeds.
Yes,
Yes, yes,
yes,
yes.
exactly. And another thing, there was because the mother is feeling that the other child is ignored.
Mhm.
One way to kind of tackle that, kind of get him involved in the care for the child.
Yes,
So
yes,
whenever they come to the hospital to see you, make sure that the other, like his elder brother, I think, I'm not sure. So
yes,
he's accompanying the child. So, and so he sees what is going on, and he does not feel that the mother is doing something extra, like where it is not necessary. Maybe sometimes those thoughts might because it's like
yes, yes,
pre-teen age group and 10 years,
yes,
so that'll be like a very sensitive age group for the child also, so that might help the
yes,
mother
yes.
also
That
and
is,
the child also.
yeah, yeah. That is a very nice suggestion. Actually, kids in preteen, they suffer from this, sibling jealousy,
Yes,
that
yes,
mother is
exactly.
giving more attention to the ill
Yes,
child. So this
exactly.
can be done. He can be
That
involved in,
involved.
small things in taking care of the child. And plus,
Exactly.
he also needs to be feel more
Yes,
important as
exactly.
well.
That he's
Yeah.
also
So
taking the decisions and
yes, 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 yeah.
yes.
So that is a very
So
good
that's
suggestion. And as mother feels that she's not, she's worried about the schooling of the child and all, because she has a lot of financial constraint. So I think NGOs also can be involved in school
yes.
rehabilitation of that elderly kid.
Yes.
Yeah.
I'm not sure which. There were a few NGOs which, actually give all the fees and the, all the equipments
Yes.
for
Yes.
the school for kids with such
Yes.
diseases and everything.
Yeah, yeah.
So,
We have done liaison with some NGO. So we have got enrolled in him in a school. We
okay.
have got him stationery also for the school, and
Yes.
workbooks and all. We have arranged this for now for this kid. Yeah.
Yeah. So that helps.
Yeah.
I thank you for bringing up the sibling part. I think it's very important to
Yes.
have a conversation with the sibling. Like as you said, the we always focus, even as healthcare professionals, when they come to OPD, everyone's focus will be on the child and the mother. Probably we don't
Exactly.
talk to the siblings. So
Yes.
siblings go through a tough time because lack of attention from parents, and they feel left out, and they feel they'll have behavioral abnormalities. So we
Yes.
have our counselors talking to siblings just to make them open up, like what do they understand. They will be very angry towards parents, they'll be very angry towards the disabled child, at least some of them, not all of them. But
Yes.
there are some siblings who feel that I need to take care of the sibling. Again, they go through, they lose their childhood. When you tell them to take care of the child, they become adult all over, and then that can impact later on in their life, as because they feel that they lost their childhood and they became a caregiver when
Yes.
they were very young. So that's something
Yes.
we need to. I'm sure you might have talked to the
Yes.
sibling
Yes.
also.
Yes, ma'am. We have conducted play therapy sessions with the elder sibling with the help of our counselor. So we also get insight into what is going on in the mind of that sibling and what he feels. Through play activities on all, they can come up with what are their thought process, and we can then intervene, like whatever can be done.
And there is a suggestion, Dr. Rishikesh is telling that at some point of time, we may need to stop going from specialist to specialist and maybe focus on I mean, just to see the patient for gentle consultations, probably. That will be
Yes,
one way
yes.
to.
So even if we like cut down on specialist consultation, like, as the time goes, but the issues are not, like, if patient, they still have to come repeatedly to the hospital because every month they require medicine refill, and that epileptic medication, their dose changes according to the weight of the child. In pediatric population, this is like a different scenario, that we have to titrate the anti-epileptic dose according to the weight. So they have to follow up, not even if not monthly, every 2 to 3 months they will have, the kid has to come, for weighing and all. And if there are breakthrough seizures, they have to come for TDM, and they have to come for physiotherapy, rehabilitation also, because in case of this kid is living far away from the hospital in very suburban area. So we tried finding out physiotherapy centers which are near to his house, so that his transport can be cut down, but we were not able to find it, so he has to come to the hospital for that physiotherapy session. So what can we do? We usually combine all the days in, like, if the patient come on one day, we make sure that he gets his physiotherapy consultation, his neurology consultation, and everything on the same day, so he doesn't have to come again and again on different days. So I think this can be done, that all the consultation can be kept on one day.
Okay. And if it is, if it's just, for the pill refill, if I'm sure you must be keeping the patient child on phone follow-ups and everything.
Yes.
So if the patient is, all right throughout the month, and it's just for the pill refill that he's coming, and maybe, you're keeping the same dosage, or even if you have to change the dosage according to the weight, it'll be helpful if you kind of liaison with a local pediatrician in the area who can,
Yes,
maybe
yes.
whom you can make sure that discusses with you regarding the dosage and everything, and so that you are also in the loop and kind of,
Yes.
because Mumbai and traveling costs, like, and with
Yes.
a child, I'm sure she must not be doing it in the local. It must be some
No,
taxi.
that is what, she is doing it in the local,
Oh
because
my
she's so
God.
poor. She has to do it in the local, and there was one this point, she's suffering from this chronic backache, because whenever she comes with the child, she has to carry that around 15-16 kg kid. So we are
Oh
trying
God.
to get wheelchair for the child,
Yeah.
foldable
Yeah.
wheelchair, so that
Yeah.
at least that whenever she has to like come, so at least there should be wheelchair, so that her some back pain should be relieved. So we are getting that as well for the child. Yeah.
So yeah, oh God, okay.
Yeah, I think there are so many points that we discussed. So I would like to ask the participants, like, I mean, any one of you think that why should we do all this in palliative care? Is it what we should do, or I mean, it's a see they've covered so many things, starting from their transport, providing a wheelchair, considering the chronic back pain for the mother. I mean, taking care of the sibling, providing siblings education, right? So it's not just medications that have worked in this particular situation, but it is a very holistic approach that we always propose. Yes, Ian, please.
I've listened and I've thought you've done an amazing job to try and support this mother and family. I'm going to ask a very provocative question. How would you feel if the mother came and said, please don't treat this chest infection. I just can't do this anymore. I know my son's never going to get any better. He's not improved over 7 years. I don't want this infection treated. How would people, I mean, this is a question not just for you, but for the whole audience. How would people feel about that scenario? Very, very hard to address. I better declare that I would find it difficult if the mother said, don't treat him. I think I would look at the suffering of the child and the family and the situation they're in, and I would be very tempted to do what she asked. But that's a massive ethical decision. And and difficult to let go. But I wondered what other people felt. Perhaps you could respond. I know that's a very, very hard question, but it's a really important point to think about, because we look at the taper, you're doing everything, but this child isn't going to change after 7 years. Year 1, year 2, I can understand there's hope, but 7 years, there's really no hope for the prognosis. So I'll be quiet now and leave you with that question.
Thank you,
Actually,
Ian, for the thought-provoking question. I think very major ethical dilemma involved in that. I would like to hear from other participants. What do they think if the mother is telling not to treat the infection next time when it comes? How would you go about it? I'm waiting for the chats to come up.
I think we have to sit with the mother, again discuss and ensure that she is very clear about what she is saying. And in addition, it is also important that we get second opinions, as was mentioned by our speaker. Perhaps get legal opinion also on this, because it's not an easy thing to take a decision on. Later, they may turn saying that it was the doctors who went ahead, even though I just put my suggestion. So it's very important to get the second opinion as far as a medical problem is concerned. A legal opinion also is necessary. And preferably these decisions are taken not in a peripheral center. These decisions should be taken from a major tertiary center where such things are dealt with, probably forming a medical board with a legal standing behind, and then only we take these things forward. Wouldn't be surprised if mother tells like that, but on an Indian context, it is not that easy for a mother to accept such kind of things. But I very well agree to what Sir Herr has said. There is nothing wrong in someone telling like that, but we have to take a decision very carefully.
I totally agree, Dr. Mohammed. I think it's very important to understand why the patient is telling like that, why the parent is asking like that, what are her concerns, and probably discussing with the multidisciplinary team, what do they think about it. And Dr. Vandana has brought up a very, very important point. Usually, these requests come from burden, caregiver burden. She must be too tired, too helpless, and it might be a sudden emotional reaction. So probably we must reconsider. Next day, when the child is fine, they might feel, no, it's okay. Let me take care of the child. So I think it must be due to a lot of caregiver burden, helplessness, and how to go about with life. So it's very important to ask what made her think like that, and to provide maybe a respite for a few days if possible. Take the responsibility from her and keep the child for a week in our hospital, so that the mother can actually get some breather. Yes, Dr. Revati, we cannot act on those kind of requests, but it is very important to make her sit down and ask where this is coming from, what is making her to tell that, and probably then having discussion, take up the discussion, give her time for 1 or 2 days, and come back again and have the discussion. So this is a long process. We may not be acting it then and there, but that is something that we need to keep discussing, and with the professionals as well as with the family and within our team. That's sorry, Rutula, please, I'd like to hear from you also.
Yeah, so I just want to say that, I completely agree with you that it sometimes might just be the emotional outburst of all the burden and all the worries that she has, and it might change the next day. it might, and I know that it is a very, very, very difficult decision to make if that is what she is wishing for. uh, in her scenario, it might be kind of multi-dimensional. There are social factors, there are financial factors which are very important. Then there is, you know, familial issues also. Like the husband is alcoholic, he's taking away the money that she earns daily. She has another child who is, finding it difficult to go to school, and all this. So it's like a multi-dimensional aspect to the decision if she is making that decision. And as someone said, very rightly said in the chat, I think Dr. Rishikesh, so he said that in cancer patients these decisions would be easier to make, and we would just be like, okay, we'll just elevate the symptoms and the suffering of the patient and be done with it. But since it is not cancer, we ourselves are not open to accepting the prognosis of the child. I wouldn't directly want to stop the treatment and not give the child antibiotics or supportive medicines, because that would help the child and not suffer as well. So as you said, maybe get the child admitted in a respite center where 24 hours care is giving, so that the mother has some break from the care that she's giving for a prolonged period of time, or in the hospital as well, wherever it's possible for the mother and the child to get admitted. Give them time to think about, give her the time to think about if that is what she really, really wants, and then respect her wishes, because I'm sure that she also wants what's best for the child, and she knows that prolonging it will him or so. Then maybe, and if as Dr. Mohammed said, if they're worried about the legal aspect of it, then take a proper written consent rather. So in our hospital we have a form, comfort care form, so we get it signed by the relatives, by the main decision maker, by the relatives as witnesses, and the physicians. So something like that, just get it written down and signed by the mother and someone else from her side of her family, and make sure that you tell them that it is not written in stone, that you can change it any point of time. So if you take the comfort care decision at present, and tomorrow or day after tomorrow she's like, no, get him admitted to the hospital, do give all the antibiotics, do everything that you can for my child, he cannot die, okay? Then do everything, because that's what it is. It's respecting her decisions, respecting her autonomy for the care of the child. But that is a personal view, and I would like if anyone has any additional thoughts.
Thank you so much. I think this was a wonderful discussion and very relevant, thought-provoking story from your side, Dr. Pratima, because this just shows the need of palliative care, where we don't think we don't have enough to do, because we don't have much to do, because this is something which we think they're already getting treatment. What else can we do? So you have opened up a window for discussion so that everyone can understand the scope of palliative care in many, many non-cancer illness, and very well suited for today's session. Thank you so much for bringing this up. And I'm so glad that you're doing this work in the place where you are. Thank you so much for that. Dr. Revati, I saw your question on withholding. We have a detailed session on withholding, withdrawing care during end of life care session. So we'll be touching upon that in detail in that session. So I'm not touching upon that right now. Thank you so much, Dr. Rutula, for a wonderful presentation from your side, and the interaction and sharing your expertise in this along with the case presentation. And thank you so much for agreeing to come for today's session. We are looking forward for more sessions from your side in the coming training programs also. Thank you so much. And
Thank
please,
you so
all
much.
the
Thank you for the
participants, give the feedback. Please kindly fill in your feedback